Hello, in this episode we begin our discussion of microcytic anemias with focusing on iron deficiency anemia and anemia of inflammation. What is the very first test to order in a patient with symptoms of anemia? That is CBC with differential. This usually includes RBC indices such as MCV and MCHC. Now, what is the very first test to order in a patient with microcytosis? That is a mean corpuscular volume of less than 80 femtoliter. The first test in microcytic anemia is iron studies. What are the differential diagnosis of microcytic anemias? Iron deficiency anemia, thalassemias, anemia of chronic disease, and sideroblastic anemia. How do we separate these for differential diagnosis? If we have low serum iron and transferrin saturation, we are dealing with iron deficiency anemia or anemia of chronic disease. Otherwise, we are dealing with thalassemias and sideroblastosis. Now, I didn't say normal serum iron or transferrin saturation because in one of the differentials, and that is anemia of sideroblastic, we have increased serum iron. So please read it exactly as I've written here. Normal or not low serum iron means sideroblastic anemia or thalassemias. Low serum iron and transferrin saturation means iron deficiency anemia or anemia of chronic disease. What factors help differentiate anemia of chronic disease and iron deficiency anemia? TIBC and ferritin among the iron indices, as well as clinical symptoms. What is the formula in terms of iron studies for iron deficiency anemia? Not only we have low serum iron and transferrin saturation, but we have high total iron binding capacity and low levels of ferritin. Now, you may hear one specific test that is referred to as free erythrocyte protoporphyrin. In what anemias the levels of this marker is elevated? In both iron deficiency anemia and lead poisoning. What is the formula in terms of serum iron studies in anemia of chronic disease? We have high ferritin and low TIBC. Now, just one quick point here. Remember transferrin saturation. Do you know how do we calculate it? It is directly correlated with serum iron and inversely correlated with TIBC. Now, I would like to draw your attention in the formula of transferrin saturation. Remember, it is serum iron divided by TIBC. Now, why transferrin saturation is low in iron deficiency anemia is obvious because we have low serum iron and high TIBC. Therefore, transferrin saturation is definitely very low. Now, the question is why transferrin saturation is also low in anemia of chronic disease. Remember, both serum iron and TIBC are reduced in anemia of chronic disease. However, serum iron is decreased out of proportion to the decreased levels of TIBC, and that's because the main process of anemia of chronic disease is iron sequestration. And because of that, we still have low levels of transferrin saturation. This is important to conceptualize the fact that both anemia of chronic disease and iron deficiency anemia are associated with low serum iron and low transferrin saturation. Now, the question is why the TIBC differs. Now, please remember that total iron binding capacity, which is how much overall binding sites on transferrin molecules are left available for binding to iron, is mainly determined by the total or stored iron quantities and to some extent also by the circulating or serum iron levels. Now, in the anemia of chronic disease, even though the circulating serum iron levels are low, the body total iron level is not low, contrary to anemia due to iron deficiency. And therefore, for example, we have high ferritin level, and don't forget that ferritin is also an inflammatory marker whose level is increased, but it's also a measurement or an index of iron store. Also, don't forget that the pathogenesis of anemia of chronic disease is iron sequestration. So we have a lot of iron stored. They are not just released into the blood so that the bacteria cannot utilize them as a protective measure against the chronic inflammatory conditions and infections. Therefore, we have enough iron in the total body iron storage reservoir and therefore the TIBC is going to be low. On the other side, in iron deficiency anemia, our ferritin and iron stores in the body are low, and therefore there's a lot of binding site available on transferrin molecules, and therefore TIBC is high. So, put it simple, the levels of TIBC and ferritin would help us differentiate a microcytic anemia with low serum iron and low transferrin saturation. In the anemia of chronic disease, we have low TIBC and high ferritin. The opposite happens in iron deficiency anemia. Now, the other means to differentiate is, of course, the clinical symptoms. So, what are the clinical symptoms in anemia of inflammation? Well, we have history of chronic illness. The top of the list are what? Infections, malignancy, and connective tissue diseases such as rheumatoid arthritis and SLE. Now, what are the clinical findings that favor iron deficiency anemia? Well, not only the patient has the general symptoms of anemia, which are fatigue, shortness of breath, tachycardia, angina, syncope, or pica, the patient has some specific findings that hints specifically towards iron deficiency, and those include pagophagia, which is pica for ice. Also, the patient has glossitis and cheilosis and koilonychia. Koilonychia is the spoon-shaped nails. You remember what is the constellation of symptoms in Palmer-Vincent syndrome? Iron deficiency anemia, esophageal webs causing dysphagia, and cheilosis and glossitis. Now, we are talking microcytic hypochromic anemia here. So what other findings are seen in PBS? We have anisocytosis, that is RBCs of different sizes, or poikilocytosis, that's RBCs of different shapes, or a combination of those, which is anisopoikilocytosis. Now, what's the reference range to measure hypochromia? We talked about MCV less than 80 femtoliters definition of microcytic, but what about hypochromic? Hypochromia, by definition, is when MCHC is less than 31% or MCH is less than 25 picogram per cell. Now, we need to have a good understanding of the sequential changes in our lab and PBS findings in iron deficiency anemia for some reasons. One is to understand the most sensitive tests, and also to understand how the so-called Menser Index is used to differentiate iron deficiency anemia from thalassemia. Now, among all the changes in labs or blood smear, what's the very first change? Anisocytosis, indicating an increased red cell distribution width, is the very first PBS change, while the changes in ferritin levels are the very first test in the labs. Now, if you are asked what is the gold standard for the diagnosis of iron deficiency anemia, that's bone marrow biopsy. However, we don't routinely perform it. Bone marrow has its specific indications. However, remember that decreased levels of ferritin in bone marrow happens before decreased levels of ferritin in serum, and therefore these are, as you can see, the most sensitive tests. Now, before discussing the rest of the sequential changes, I want to draw your attention to the Menser Index. Okay, what is Menser's core or Menser Index? It's an index that helps us understand the most significant change in thalassemia as opposed to the most significant change in iron deficiency anemia. It's defined by subdividing MCV value to RBC count. Don't worry about the units for now. Now, remember that in iron deficiency anemia, we have earlier and more striking reduction on RBC number, again, out of proportion to reduction of MCV, and earlier than changes in MCV. Always remember that MCV change is the last laboratory change in iron deficiency anemia. Because RBC reduction is out of proportion to MCV reduction, in iron deficiency anemia, the Menser Index is greater than 13, okay? However, on thalassemia, we have the opposite. In thalassemia, from the very beginning, we have reduced size of all cells. We do not have much anisocytosis. Red cell distribution width is not increased. We do not have sizes of cells that are normal or small. All of the RBCs are small, therefore the size distribution is not very wide. So we say red cell distribution width contrary to iron deficiency anemia, is not increased in thalassemia. The other way to say this is we have from the very beginning reduction of the size of RBCs as the first change in thalassemia labs, and therefore because reduction of MCV happens earlier and out of proportion to the reduction of RBCs in the thalassemias, the Menser Index is less than 13. So this is another way to say red cell distribution width is narrow and MCV changes is more striking and happens earlier. This is a very important clinical index that helps differentiate thalassemias from iron deficiency anemia, though we have other means to differentiate them that we will discuss them in the thalassemia episode. And I promise these two formulas, the transferrin saturation and Menser Index, are the only formulas I'm going to talk about in this episode. But please commit this to memory, as these two findings are pretty much the best way to differentiate iron deficiency anemia, anemia of chronic disease, and thalassemias if you have just this limited information based on these indices. Okay, now let's return back to our discussion of the sequential changes in iron deficiency anemia. Ferritin in bone marrow is the first change, and then we have reduced ferritin in the serum. Next, we have increased liver synthesis of transferrin as a compensatory response. This also translates into increased TIBC levels. After these changes of ferritin, transferrin, and TIBC, we finally have our iron studies showing serum iron reduced. The calculations were forward show TIBC is increased and transferrin saturation is decreased. After all of these, we have reduced hemoglobin before the changes in MCV, and the very last change is reduction of MCV. Remember the top ones, transferrin after ferritin, these are the very first changes. Ferritin is the very first, and the two last one, hemoglobin change, and the very last one is MCV reduction. Okay, let me bring my camera a bit lower. Don't get too excited about this. Okay, so what's the treatment of iron deficiency anemia? Well, treatment is iron supplementation. Now, there are a lot of points to remember. The very first and the simplest way to understand this is if the cases are not complicated, we use oral iron supplementation. Otherwise, we use IV iron supplementation in the complicated cases. Now, before discussing what do we mean by complicated iron deficiency anemia, remember that if the patient is non-responder to oral supplementation, we use intramuscular route. Okay. What patients are considered those with complicated iron deficiency anemia? Any malabsorption syndrome. The top of the list is gluten sensitivity and celiac disease, but we have any type of malabsorption requiring IV iron supplementation. The other examples of post-gastric bypass, IBD, or even iron intolerance. That's a patient who cannot tolerate oral iron supplements. Next category is a person with ongoing blood loss. That could be GI, GU, acute or chronic, any type. That person also requires IV. Next is the patient who is either pregnant or has hyperemesis gravidarum during pregnancy, specifically requires IV. Next, we have patients with chronic disease. These specifically include malignancy, congestive heart failure, and chronic kidney disease. And finally, remember that if the patient has any side effects to oral iron supplements, they also need to receive IV. Now, one side effect of IV iron supplementation is allergic reaction to iron dextran injections, and it's shown that iron sucrose IV preparations are less allergic. But if the patient does not have any of these indications, we use oral iron supplementation. There are just a couple points to remember. The treatment usually should be ongoing for 4 to 6 months. And there is GI side effects such as both constipation and less commonly diarrhea and dark stool, especially with sulfate formulations. As I mentioned, if there is not enough response to the oral route, we initiate with IM route, not directly going to IV route. Okay, that takes care of our discussion for iron deficiency anemia. Now let's just draw our attention a little bit to another microcytic anemia with low serum iron and low transferrin saturation. And we are mentioning that we differentiated from iron deficiency anemia by TIBC and ferritin. What do we mean by that? We have low TIBC. We discussed why, because in anemia of chronic disease, the stores are not reduced, and therefore another difference is we have also high ferritin. Another mechanism of high ferritin is it's an acute phase reactant and it's an inflammatory marker, better say, and that's another reason why its level is increased. Now about the pathogenesis. What is the pathogenesis of anemia of chronic disease? Inflammatory markers result in increased levels and functions of hepcidin. If you remember from hemochromatosis, the simplified way to express the function of hepcidin is to say hepcidin causes decreased absorption of iron from the intestinal lumen into the serum. That's opposite of what happens in hemochromatosis that we have here in anemia of chronic disease. And as a result of impaired transport, the iron would build up inside of the cell. This is the concept of sequestration of iron, and that is a defense mechanism against chronic inflammation and infections. A second thing that happens is chronic inflammation, especially in the form of chronic kidney disease, is associated with reduced erythropoietin. And that's the second arm of anemia that happens during the inflammation and chronic disease. What's the treatment of anemia of chronic disease? Treatment mainly includes treating the underlying disease. In the case of chronic kidney disease, we consider erythropoietin supplementation. Very important, but last clinical question of this episode. When we use erythropoietin for the treatment of anemia of chronic disease in patients with chronic kidney disease, what side effect is likely to happen? The patients with chronic kidney disease already have the possibility of hypertension, and providing erythropoietin increases or worsens the hypertension in patients with chronic kidney disease. That could be a limiting factor for our treatment. To summarize, in this episode we discussed two of the four important differential diagnoses of microcytic anemia. Remember, if iron studies show low serum iron and transferrin saturation, we are dealing with iron deficiency anemia and anemia of chronic disease. To differentiate them, we pay attention to patients' clinical findings as well as TIBC and ferritin level. TIBC and ferritin are mirror image of one another. In anemia of chronic disease, we have high ferritin and low TIBC. In iron deficiency anemia, we have low ferritin and high TIBC. Next, we will discuss the other differentials of microcytic anemias, and those are the conditions in which we do not have reduced serum iron and transferrin saturation, namely sideroblastic anemias and thalassemias.